We do have a series of continued series of webinars for the Improving Ohio Health webinar series, which we will send all attendees. I will send you some information as well on some other webinars that we have scheduled, along with a copy of today's slide deck. Again, today's webinar is being recorded and will be posted to the CliniSync YouTube page probably within the next 2 or 3 days. With that, I'm going to turn it over to my partner in crime, Miss Cathy Costello.
Hey everybody, good afternoon. I hope you're enjoying this day. And I have to say before we start, you can see what our theme's going to be here. And we have to say, yay, Cam!
Yay,
For someone who grew up in Cleveland, talk about understanding long suffering. So I just want you all to enjoy an Ohio-based webinar and recognize our status and sympathize for those poor people for the rest of this week, and hope that by the end of the week things are very calm.
But we do guarantee no success for the Browns. So.
Oh, if we could do that, we'd be making, we could really do well. But anyway, okay, so what we're going to do today is to cover the hospital data that we've been collecting, and maybe I should take a step back and explain where we are. A lot of you have followed us through this journey and actually have participated in what we're doing with the Ohio Department of Health. But let's give you, once again, a high-level view of what we are trying to accomplish on behalf of the Ohio Department of Health, who in turn is working in partnership with CDC, Center for Disease Control, to collect data. I mean, this is a very large grant for Ohio, and one part of it is to collect data on diabetes and hypertension, both inpatient and ambulatory. One part has to do with patient education. One part has to do with wellness and nutrition. One has to do with setting up pre-diabetes screenings and get into the workflow. And there are 6 counties that are doing intensive work at the local level to do patient education and work with practices on workflow issues. So it's a very, very broad scope grant, but the whole intent for Ohio and the other 16 states that received the dollars for this in-depth grant is really to see how states are doing with their chronic care management for conditions that are driven by diabetes and hypertension. And then what can we do about it on the ambulatory side to help improve those statistics. So that's where we are. We're looking at what last year showed, what we're showing this year for our inpatient data, and then we're going to talk a bit about the ambulatory data too. So just to begin the discussion and look at Ohio data, this is updated data that the American Diabetes Association has provided. And what they're saying now is 13.5% of all Ohioans have diabetes. And that represents over 1.3 million Ohioans, which is a significant increase just in the past couple of years. So this is not something that, you know, we can kind of say as public health measure is not important. It probably drives a lot of the public health initiatives and priorities in Ohio are driven by the whole question of chronic care management and what we're going to do about it.
Yeah, because a large portion of those Ohioans with diabetes also have another chronic complex condition, which, you know, makes the cost of providing health care dramatically increase, and also increases the importance of the chronic care management programs.
Right, and as we all know, CMS has just gone crazy on payment reform and the cost of health care. And they're doing that is because the costs have gotten crazy. Mm-hmm. And so in Ohio, in tracking this back to a local figure, they estimate that $12 billion a year in Ohio are spent on chronic conditions. That this would include diabetes, hypertension, heart disease, asthma, COPD, things that arise from poorly controlled hypertension. So it's not just a theoretical discussion for those of us in Ohio, but it's a real discussion. And Ohio, at the last time we checked for last year, was 7th in the country with the number of diabetics in the population. So it is important that we all develop that game plan around this. Now, while we're talking game plans, you probably, after hearing that little intro, are thinking, oh my gosh, how many times can I hear this, because it's coming at you from all sides. And we understand that, really. Every single public health agency, payer, health care organization, if you're part of a system, or even if you're in a small practice, the message is the same. You have to do something. You have to screen for chronic conditions. You have to manage those. You have to track them, provide patient education, community connections, healthy eating, exercise, and do all this at a reduced cost.
And this is all becoming even more important, because not only is it important to care for your patients and to try to assist them with, improving their care, but now with these new payment reform models, the providers' future compensation depends on managing that entire patient and really working to lower overall costs for managing these chronic patients,
So some of this relates back, and what we're trying to do is to help you dig out from what are enormous amounts of detail that are, in its most inimitable fashion, CMS has tried to address issues that they view as major public health concerns. And certainly diabetes and hypertension arise to the top of that. But in like fashion, as all of you know who have ever done a program that goes back to Medicare, CMS has buried people in details. And chronic care management is not an exception to that. When CMS started just within the past couple of years to allow practices and hospitals to bill for transitional care when the patient comes out of the hospital, and you want to follow up with them immediately to make sure that they are okay and are not going to end up back in the hospital, or when they do chronic care management, CMS recognized the need there, but what they did is put in a ton of details that go into how you create these programs. And so what's happened, we just kind of, to digress for a second, CMS has really showered us kind of endlessly this year with new regulations, and one of them just came out last Monday. And the several, shall we say, probably 10 to 20 pages has to do with chronic care management and how they're changing those programs, what they expect to see out of them. And for all of you who are trying to set up these programs, the good news is that they're backing off a lot of the very fine details that they wanted you to comply with, and in order to set up one of these programs. So basically, and we'll have more information for you about this over the next month as we get involved in talking about some of these proposed regulations. But the thing to keep in mind here is CMS is now looking, these programs are looking more like they're really driving towards the treatment of patients with chronic conditions, right, and less about the paperwork around it. And so I think that's good news for everybody. Absolutely.
Yeah, I think and now so many people were focused on the proposed macro regulations, which are huge, but keep in mind that these other regulations we're talking about contain changes to meaningful use, PQRS, TCM, CCM. So, if you are bored and you need some reading material, look at the hospital inpatient fee service proposal. The hospital outpatient contains some meaningful use changes. The physician fee for service proposed fee schedule And there was several other smaller rules which contain some minor changes to reporting programs or healthcare IT in general. Now, we are scheduling a webinar, not part of this series, but it kind of as part of our general CliniSync Plus offerings. This webinar will be Thursday, August 11th at noon. We will send the link to everybody who's attending this webinar today. This webinar will focus, this webinar on August 11th will focus on all of these proposed rules that are out there, just kind of trying to get our hands around what all these proposed changes will encompass.
Yeah, and we will have a section where we talk about the transitional care management and chronic care management changes, because another thing that's really important for you to understand with this in trying to work with patients with chronic conditions is a whole nother area of this that CMS has carved out in these new regs, has to do with behavioral health and primary care integration around chronic care management. And so even though you could always include behavioral health as one of those chronic conditions that you're seeking to manage, now CMS is creating a whole new set of codes around that specifically. And then the other thing that they're doing that's worth noting, because any of you who are attempting to do chronic care management recognize that the amount of time that CMS has allotted to helping to manage these patients, the amount of time that the physician or other provider may see them, and the amount of time that the office staff or support personnel may interact with them is not really covered in normal coding. And so one of the changes we see in these regs is CMS is going to allow for increased time that can be billed under new codes that allow you, if you run over your allotted time for a normal office visit, you can then code under one of these separate codes to cover chronic care management within the patient visit, as well as chronic care management that can be done between patient visits. So this is all like a new and evolving area. And so I think that the goal is, even though I'm sure you can get overwhelmed with everything that's going on, the good news is I think people are trying to move practices back to the concept of just caring for the patient and not getting involved in the details.
Yeah, it's a novel concept, isn't
it? Practicing medicine, geez, wow. But anyway, so as you can see, Cleveland is still intact, at least as of right now. So let's look back on 2014 data. Let's look at where we are with all the data that has been collected as part of this grant to date. And just as a reminder, the grant is actually going to cover 4+ years in the sense of our data collection. There are other aspects of it that run on slightly different timelines. But the goal is that, and we'll talk about this in the data we're reviewing today, that there is, the data points for 2 years really don't set a trending, and it's hard to analyze it in terms of trending, but hopefully as we move over the next few years, we'll be able to have a better handle around that.
Yeah,
So,
and this grant, Ohio was one of only 17 states to get this grant funding, so we're really excited to have this, this money in our state so we can really try to make a difference. And this money is used at various levels. There are some local initiatives where they've got some local education programs for pre-diabetes. There's some programs that are really trying to train patients that have diabetes or have been identified as pre-diabetic with, healthy shopping. There's some physician focused education that's being provided. And then there's the work that Cathy and I are doing that's focused on, collecting some data from around the state and providing some education on how to leverage your current healthcare IT or your current EHRs with managing these patients and really making a difference.
So where we started baseline was last year we collected data, but it went back to 2014. So it's not quite 2 years, about a year and a half ago. And we started with the inpatient side. It was more standardized data and more easily accessible. And what we found for 2014, we were looking at 1.1 million discharges overall in Ohio hospitals. And of those 1.1 million discharges, 43% had diabetes identified in the problem list. And almost 60% had hypertension identified in the problem list. In 15% of the cases, individuals had both diabetes and hypertension identified in the problem list. So it kind of set the baseline as to where we go from here and where Ohio was at that certain point in time. So we took those 2014 figures and broke it out by discharge by region, because we wanted to see if we could see variations, and then as the grant moves along and there's more information from the ambulatory side and there's education programs on the ambulatory side, does this then in turn impact back to the inpatient figures? And so it's kind of a big loop, but to bring it down to the local level, we're looking at, as baseline data, the highest diabetes figure for the regions as far as 2014 data was in the Southeast region, where over 47% of the patients were identified with diabetes. And the same region also had the highest hypertension figures, 60%. So this is where we are starting, and where we, as we drew 2015 data, we were looking back into these 6 regions to see exactly what was going on. Okay, so where we move into now in 2015. And this is what we're looking at for hospital discharges in 2015 by region. And the regions have, in Ohio overall, for 2015, you want to look at, as I said, we can't really establish trending for just 2 years, 2 data points, but we can look at it. And what I would say right now is, based upon everything that we're seeing, Ohio is holding its own. We had the difference in discharges between 2014 and 2015 was 10,000 discharges over 1.1 million discharges overall. And so the increase was less than 1%. And that in and of itself, I think, is a significant figure, because Ohio, like most of this section of the country, has an aging population and higher Medicare figures. And, you know, it's predicted over the next 10 years that this is going to put an enormous load on the state infrastructure and certainly on Medicare. And so it's really important that we understand where those figures are and how they're impacting what's going on at the local level.
And all of the new payment reform models are really focused on keeping patients out of the ED, keeping patients out of the inpatient setting, and, you know, managing those patients in the ambulatory and the outpatient setting. So we're hoping that, well, we being CMS and everyone in healthcare, that over the next 2 to 3 years, we see that number drop. But as you can see here, the numbers are, from a mathematical standpoint, they're statistically flat.
Yeah, and considering the Medicare population in Ohio went up close to 5% in 5 years, I think 4%, it's important to recognize what it means to have basically a flat line for both diabetes and hypertension and all your, generally, the hospital inpatient discharges. So
while the numbers are flat, the aging population actually you would think it would trend upwards, where we're remaining flat. So flat is actually an improvement.
Yeah, exactly. So in Ohio overall, in 2015, the number of discharges of diabetes was 42.9% compared with 43.1%. As I said, and as some of our better statisticians will tell you, that is not in and of itself statistically significant yet. But as we said, it is important that we haven't trended up. And the same thing's true with hypertension. We've gone from 56.2 to 56.1 in 2015. And so the good news is that in the diabetes area, all except one region showed a slight decrease in the number of patients who were discharged, or the number of discharges that showed the patient had diabetes. So it is a good thing that we're seeing right now. The hypertension was a little not level, but as close to level as it could be. So we're going to have to look at that again next year as the 2016 data becomes available.
And I think it's great to note that for the hospital discharge data, we have a very good standardized data set from across years, thanks in part to the Ohio Hospital Association, who collects this data from hospitals across the state and has provided us with access to their data. So thank you to OHA for their participation in the data they shared.
Yeah, and I call out the Southwest region. They have been party to what's called the CPCI grant for about 3 or 4 years, which is actually designed to help manage chronic conditions. And they ended up with, as a regional average, the greatest decrease, and that was 0.8% decrease. So good job in Cincinnati and the surrounding areas. All right, so how is it that CMS links what is going on in the inpatient, in the ambulatory area? And they have set up a method that was designed by ARHQ, which is the Agency for Healthcare Research and Quality. And for those of you who don't do the data geeky thing like Scott and I do, the reality is ARHQ is like the research arm for CMS. And so they're the ones that do the studies and put together statistics and make suggestions as to how data can be managed better. And so in this area, what they did, and it's really been fairly recent that they set up these categories, but they set up new categories called Ambulatory Care-Sensitive Conditions, or ACSC. And these are conditions that, given the amount of data that they have looked at, and Lord knows if you've been party to meaningful use, you know they have a lot of data to look at. And so the reality is, as they try to make sense of what they're seeing, and that's the one good thing I can say about CMS, as much as it can be difficult to have to report as much data as we all do. The reality is, if it can be used to go to population health and make some really significant change in that area, then it's not a bad thing. And this is one of those areas where I think they put their finger on what is truly an area of need, and that is these ambulatory care sensitive conditions. And these are, for the most part, chronic conditions that as the patient comes into the hospital, the ARHQ has identified certain conditions that they feel, if the patient could be managed more effectively on the ambulatory side, that it could definitely decrease the incidence of times when the patients are admitted or show up in the ED. And the ones that track back that you hear the most about and show up in most of CMS's literature are diabetes, COPD, asthma, and heart failure. And those are the 4 conditions that are tracked for every single CMS beneficiary, a Medicare beneficiary, and that information is provided to every single practitioner in the country for the patients that they work with, to show how many of those patients that they see have one of those 4 conditions, how many of them have been hospitalized. And of course they don't say you can find out what in your information, what the diagnosis was, but whether or not it's caused by the chronic condition, there is an assumption that the chronic condition has contributed to the fact that they have been admitted. So, as we're doing, and as we talked about earlier, the tracking on the ambulatory side is a little bit trickier than what's going on the hospital side, because as Scott mentioned, the hospital data is driven by OHA, and it's the hospitals are all required to report into the OHA's central data bank, which then becomes the data repository for Ohio hospital data for the state of Ohio.
It's not quite that easy on the ambulatory side.
On the ambulatory side, all of you, and we recognize a number of people on the phone, know that you recognize how much more difficult, and the situations can vary from one practice site to another, or from one section of the state to another, or from another variable is electronic health record system.
And not everybody's reporting the same clinical quality measures. Quite honestly, some of the clinical quality measures don't make sense for specialties. And then there's a lot of variance even around how your EHR is configured that dramatically impacts the measures, specifically those that we're interested in for this project.
Yeah, and it was unfortunate. It was something that none of the states had any control over, but apparently, and many of you who work in the ambulatory area will recognize this as soon as we say it. But in 2015, as we got closer to the end of the year and they were talking about reporting quality data, all of a sudden CMS came out with a pronouncement that they had actually built the logic incorrectly for which measure of all measures to have the problem with. It was with the diabetes hemoglobin A1C measure. That is probably one of the 2 or 3 most reported metrics nationally. And so this fed into our data collection because that represents NQF 0059, which is something that you all have reported to us. And so when we talk about it, we're going to flip over to the next slide. Just keep in mind that we are telling you what data has been reported to us for this point in time, but there may be other issues that we won't be able to really adequately identify and report on until we see the trending over the next couple of years. But of the 2 measures that we do track under this grant, it is the 0059, hemoglobin A1C is greater than 9%, and 0018, which is the blood pressure well controlled, which is less than 140/90 millimeters, I can never say it, millimeters of mercury. But what I would say is that these are important metrics, even recognizing that there may be logic problems within your EHR system, and hopefully those have all been corrected with upgrades for 2016. It's still important that you track that, because that list of patients that you can develop from that are the ones that then become the basis for any chronic care management that you would do.
And we're also seeing these 2 measures pop up in the various reporting programs. In PQRS, these were both kind of cross-cutting measures. These are both measures in the ACO reporting program.
That's right.
A lot of your private payers are wanting to look at these 2 measures because all these groups really see these 2 measures as drivers for costs for the patients with chronic conditions.
And what we'd say, and we're starting to see as groups become more sophisticated in what is, as we said, an overwhelming amount of data, and trying to make use of it in the best way possible, is we see a lot of programs that are actually going with best practices at the national level, which reflect values or metrics that are being tracked at what I call a higher level than these 2, where you might be tracking your A1Cs at less than 8 or even less than 7, depending on what you're tracking. Some of those, if you're part of an ACO, You know that the diabetes bundle has both greater than 9 and less than 8. And some of the American Diabetes Association and the CDC are pushing even lower figures. But for what this grant is doing, it is basically helping people to recognize what their patient population is. And then if you wish to go on and report what I call a higher level of best practice, more power to you. But this hopefully will help you sort out the patients that you may not even have an A1C within the past year. And that's one of the triggers to make them poorly controlled. So with that?
Yeah, now we're going to talk a little bit about what we're reporting, how we've collected this data. And first, I want to say that CMS does not have a public data set. There's not a database that we can access to say, hey, show me these 2 measures for all providers in Ohio that have reported this information. It's just not there. So what we've tried
I'm guessing CMS has it,
yeah.
And it may be available to researchers, but for us, I mean, we've looked everywhere for this in the PQRS data, and we just can't find it for Ohio. We have the national benchmarks, which we'll share with you in a second.
But if somebody out there listening to this webinar has access to that data or knows where to get it, let us know.
Yeah, really.
So what we're going to look at today is data that we've been able to collect from organizations across the state. We're still trying to collect 2014 and 2015 CQM data. If you're on this webinar and you've not sent us your data and not participated, we ask that you do, and we'll probably be reaching out to you. But if you haven't sent us data, are interested in becoming, part of this solution, please contact us. We would love to get your data. With that, let's take a look.
Okay. So as we said, we had begun in 2014. But we're really picked up speed with 2015 data, although we're still in the process of collecting it. So we're reporting out the 2015 because we're feeling that we're reaching more of a critical mass in the various regions to talk about it. So while we look at this, let's talk about what the national benchmarks are for these 2 measures. And these national benchmarks are set by CMS using the PQRS data, which is the quality reporting data that are submitted each year. And for diabetes, for the country, the benchmark figure is 28.4%.
Keep in mind, that's a reverse measure. Lower is better.
Yes, and that means that the reason you want lower is better is that means that fewer of your patients are out of control. And then the benchmark for hypertension is 69%. So in this one, the higher is better. More of your patients are in control as far as hypertension. And so what you're seeing here is of those practices reporting, and I have to emphasize that, we're still collecting data here, and this may change over time, but of the practices reporting right now, we're actually showing good success that 18.2% of the patients are poorly controlled. So that means that over 80% of the patients are under 9% A1C figure. And so I think this is a good metric, but I do caution you because of the fact that we know the CMS have put out information that at least one of the major vendors, very major in Ohio, had problems with the tracking of this metric in some sites, not everywhere, but in some sites, that we had to take that into account for this data. And that's one of the reasons why we're cautioning you, look at it for information on your region, but recognize that we're going to have to wait probably until we get all of 2015 and then 2016 in to have a better sense of the diabetes.
And for those systems that we knew had problems with the data, we excluded those various data points. And you'll see in the Northeast region on this slide, due to that issue and the fact that we just didn't have enough participating organizations, we really didn't have a figure to share, at least for the diabetes figure.
I think that one we had enough, but there were issues on some of that. And so we see the range from basically 12.3%, which again is that Southwest region where they have that CPC plus grant or CPCI grant, and all the way up to 42% in Central Ohio. And then the blood pressure readings, the Southeast region was 59% was the lowest in compliance, so basically close to 60%, which I don't think is super bad or anything. And it goes all the way up to 78% in the Northeast region of patients who are hypertension under control. So I think this is excellent that Ohio as a state overall is doing well in what they're doing to control both diabetes and hypertension.
Sorry guys, I just got a note that there's a line around the screen and can't see anything on the screen. So
Can't see it all, but they can't see it all.
All right, well what I'm going to do here is just I want to make sure that we're sharing things appropriately.
Okay.
All right.
We hope that's better. Whoever let us know about that, we apologize if there's some problem with that.
All right.
Okay. So anyway, what we're seeing is, I'd say, is a good baseline for where we want to be, but because this data is going to become more and more significant the more providers that are participating, we are asking you, as we mentioned, to try to join this grant so that we have a complete picture of that. And then I would say we hesitate to do that this year, but I think starting next year we'll try to compare what we're seeing on the ambulatory side with what we're seeing on the inpatient, because by that time so many of the chronic care management programs and transitional care management will have been underway for at least a year, if not 2 years, and hopefully we'll be seeing more improvement in those areas. I'll let you go ahead.
No.
Okay.
Yeah.
Okay. So what we did here, because we had a lot of interest in this when we published this last year, and it is out as an article for the 2014 data, and this will be out within the next month for the 2014-2015 data. But what this does is compare overall where we are in each county for discharges related to diabetes and hypertension. And as you can see, there are some variations, but there are some states who are doing, or states, I'm sorry, counties, State of Franklin or whatever that movie is. But the counties are doing, I think, a good job. I don't think we see any significantly high increases in either diabetes or hypertension in the counties. And we hopefully are right at the cusp of looking at the downward trending. And as I said, I think this will be more significant as an analysis at the end of this year when we are able to add 2016 data, because then you're looking at whether or not you are creating trending patterns.
Yeah, I mean, the biggest change I see on this slide, there looks like there's about a 5% change from 2014 to 2015 in diabetes. Where was that? In Fayette. But again, if you are a statistician, these are statistically flat, and it's really hard to call 2 years a trend.
Yeah, so we have all the counties laid out for differences in diabetes and hypertension reporting, and so we'll let you go through and look for your own county and see how it reports.
And again, you will receive a copy of this slide deck after the webinar concludes.
So the bottom line is we showed just a slight improvement in both the diabetes and hypertension, less than 0.5% in the state overall. But it is something that as we continue to work on it, As I said, I think this year, the year we're in now, is going to be the most significant as part of this grant in determining whether or not we're making a difference as these programs are being set up around the state.
And as we shared a few slides ago, again, there's an increasing number of the aging population. So one could make the argument that statistically flat is in fact an improvement between years.
Yeah. And so with that, let's see if we have any questions.
All right. Check real quick, see if we have any, and then we'll move to the next. All right. Give me just a second here, folks, to pop up the question box. Okay, there was only one question about speakers.
Yeah, and what we would reiterate is watch for information coming out on these new chronic care management programs, because if you have not been involved in setting one up, that should be a fairly high priority for you all. And I think CMS likes us to talk about these things in terms of payment reform, because that's where their head is right now. That's how they're being driven by Congress. But the reality is it's better patient care. And I think it actually goes back to the days when you could call your primary care doctor and get somebody in the middle of the night to respond. And that's pretty much what these programs are doing, is going back and mimicking a very hands-on, personalized care for the patients that need your help the most. And that it's not that, doc, my stomach hurts, should I go to the emergency room? But rather it's that ongoing care for two conditions that can really affect quality of life for your patients. And so I think that's where we're headed. As I said, I'm less concerned about the payment reform side of it right now, and a lot more concerned about the clinical and patient-oriented issues.
It's kind of really transitioning to managing the holistic patient. Don't manage a condition, manage the patient.
Right, and get into the patient portal and some of the other uses of your EHR. Yeah. And so with that, I'd say we'll be covering more information on how to. Okay. I'm sorry. Go ahead.
We do have some other. Sorry, I didn't know you.
You can tell it's been a long day.
It's been a long morning, and the coffee's starting to wear off.
Yeah, they cut me off at 3 cups of coffee, so I'm in need. You can tell.
We still have a few slides to go, and we're still within our time frame. So let's.
Okay. Okay, so I would say we are going to have to, as I think we had reiterated earlier, that it's next year we're going to be looking at this and really able to parse this out and make sense of it on a regional basis. And I think you were going to, Cathy, you want to throw yourself on the mic and plead for more data.
Yeah.
Please.
Yeah, we really, there's a pretty good data set that we need, but primarily we need your CQMs, the 0059 and 0018 from 2014 and 2015. We'll take those in any format that you can provide us, whether it's your meaningful use reports from 2014, 2015, your PQRS reports, any format. We want to make it as easy as possible on you to provide us with your data. As you can see, your data is completely de-identified. We do have our data we do maintain some information about how to identify these organizations so that we can draw reference to improvements from one year to the next. But when we submit the data to ODH and CDC, it is completely identified. We de-identified. So we really, really, really need more participants. And we do have some other webinars coming up.
Yeah. So between our technical webinars and ones on the effect of payment reform, the ones about how to connect with people in your particular region who can help support your patients with diabetes and hypertension, I think that one's going to be especially interesting to people to see how you can network on a more formal basis to help support your patients.
Yeah, and the next webinar is one that I'm putting together. It's going to be on, really, it's titled Technology Tactics to Make Patient Engagement Easier, but really it's going to be focused on how you can connect with your patients and stay connected with them through your portal and some other means that you probably already have. There's a lot of work groups out there. CMS has work groups, HIMSS has work groups that are focused on true patient engagement. And I'm going to try to cover some of that in the next webinar, which is coming up next week. And then after that, we have Making Your Patient's Care Plan Come Alive. And that one is going to be focused on the work that we're doing with the HIE in connecting the entire community. You know, interoperability in past years has really been focused on, let's share information between the hospital and the providers, whether it was results or discharge instructions. But now we're trying to get out beyond that and say, how can we connect the entire spectrum of care, not only hospitals and physicians, but post-acute, and then those local organizations, the faith-based organizations that are kind of non-traditional providers of care, but play an important piece in keeping the sick patients healthy.
Right. Right.
And then we've got the impact of the new payment reform regulations, which we're still trying to digest that because they got impacted again last week.
But even though those are proposed, Scott and I have thrown this around whether or not we want to wait until regs become final. But the reality is, I think you need to understand how things are moving ahead in order to plan for next year, for 2017. And these regs, no matter how large they are and no matter what we think of them, they will be finalized in some form this year. So we're going to cover quite a few changes that are being pushed for chronic care management and transitional care management. We'll do that as its own webinar to talk about when you set up these programs, things to think about under the new regulations.
Now, I am going to forewarn you with that webinar, we are not going to get into the weeds of macro. We are going to talk about some of the macro concepts, but we're going to be focusing specifically on CCM and TCM modifications that are contained in macro, as well as some other recently.
2 or 3 other regs too.
And then the last one on this page is where I'm actually going to try to get some other groups together, some clinicians that are leveraging functionality within their EHR to manage those patients, kind of show how they're doing it. So maybe that'll trigger some thought in other participants that are struggling with the EHR tools that they have available, because I'm a true believer that you don't need to buy a new application to do this. Your EHR can do this management of your patients. You might just need to write a few little ad hoc reports or use a tool that you're not currently using.
So with that being said,
let's check our questions again.
Yep.
And you can see LeBron carrying his baby, which is kind of significant since he carried the entire team on his back and led in every statistical category tracked. We have no questions. Let me check the chat box.
Okay.
Yeah, we would strongly encourage you to sign up for our CliniSync newsletter. Dottie, our communications director, does an absolutely great job. There's actually in the lower left-hand corner of the screen kind of a little snapshot from one of our past ones. But we have announcements in all of our webinars. We talk about different programs we've got going. And, of course, we share a lot of information about the HIE and all these crazy federal regs. But please, if you have any questions, don't hesitate to email Cathy or myself. Quite honestly, most of you folks that are attending this webinar probably have have had our contact info for quite a while, but don't hesitate. This is what we're here for. If you are someone who's attending and hasn't sent us data yet, please send us your data. Please. So again, thank you all for attending.
Thanks.
We will be posting a recording of this webinar very soon.
Have a great day.